Yes, we got buy-in from the docs, and they actually like the tools that go along with SBIRT, and then really set up some linkages for referrals, able to train the social work staff not only on SBIRT, but also on community referrals and some interventions or things that they could do to talk to people about their drinking and help them identify, where they are in terms of stages of change, and really talk to them about some options. But some is the concern over some of the pain management and medications around pain management, because obviously there's a lot of attention on, prescriptions for pain meds, and addiction to opiates and deaths, really, from opiate addiction and overdose. And also wanting to really be able to provide care for people that's accessible and affordable. And one of the things about being uninsured is that your options for treatment are often very limited. And so what we're really trying to do is to increase the awareness of addiction and also increase identifying people who are at risk.
Yeah, I did heroin the first time at 14, and that always remained to be my drug of choice. I had a motorcycle accident, and I raced dirt bikes growing up, and remember Percodan at the time, and then my wisdom teeth extracted, and then always hanging out, but it was always opiates. What would be, if I had anything on the table, the opiates is what I would go to. And the heroin back in those days was pretty clean, so, but then later on, Percocets, it progressed to that to even Versed and fentanyl, which was some pretty strong stuff I got in the hospital. I diverted narcotics and all that, just didn't get caught. I went to jail numerous times, but this time I went to jail for 13 months. And I remember the judge saying to me, Miss Stacy, do you want to go to prison? Because every time I'd get out, there'd be a series of relapse, treatment, jail. And it just kept going on and on and on for years, 5 years. And, no, I don't want to go to prison. But that's when I finally decided that, I can't stay clean. And I got very suicidal. And somebody mentioned methadone.
Patients who come in are screened and then come in and they have a full assessment by the social worker that was developed by the team, and then the social worker works with the primary care provider, talks about whether or not that person would be appropriate for the induction, and if so, schedules the induction, and if not, then the social worker works with them and the primary care provider to find an appropriate treatment for them. To train the medical providers so that they use the SBIRT tools and identify people who could potentially have alcohol problems or who are at risk for alcohol addiction and talk to them. Because one of the things we know is that if people hear it from their primary care provider, then that has an impact for them.
Buprenorphine is a prescription medication that's used to treat opioid addiction and opioid dependence. Recognizing the need to help people get off drugs to which they're addicted, the medication buprenorphine was approved to be prescribed in the doctor's office. It's sort of similar to the model of methadone, but without a lot of the disadvantages of methadone.
And it was the behavior. It doesn't change. Once that buprenorphine locks into the receptors, it doesn't make you high. You just feel you don't have any cravings. And it was just the behavior.
One of the things we're also doing is really putting some workflows in place so that we're screening people coming in, because obviously we want to make sure people that we start on the treatment are people who are going to be successful. It's not, appropriate for everybody, just like there is no one treatment that works for everybody who's experiencing addiction. We've talked about this internally. What we really envision is that a majority of our providers in all of our centers will be certified to at least do the maintenance, and that we will have multiple providers in every center who do the inductions. One, because you can't just have one person doing it because you need coverage. If that person goes on vacation or does something, you need to have someone who, you know, has that level of experience and training to cover, but also just because it will be more accessible across our centers.
Well, I think my number one advice is to consider a comprehensive treatment. I think it's extremely important to be connected with the primary care providers, social workers, psychologists, case managers. So you will bring all those disciplines together to be able to provide 100% care to those individuals.
I would say go for it. I would say also that to be very cautious. If you can have someone dispense it to you, that would be wise, because as addicts, you know, if one's good, two's better. And I wouldn't want anyone to make that mistake. That I did that initially, and it was just a waste. It's a waste of money. It's expensive medication. My insurance covers it, thank God. But you know, that behavior was still there, and that was early on. So I would say to anybody, to any opiate addict, to give it a chance. To give it a chance. But I see a future of hope, you know, of hope and like I said, those liquid handcuffs, that methadone and that nasty, all that stuff. I see that broke, and and I'm breaking the cycle to my granddaughter. You know, she won't have a junkie for a grandmother, you know. And that's very profound.